Okay. Hello, everyone, and welcome to the Winter 2018 Geriatric Healthcare Lecture Series. My name is Barbara Cochran. I'm the Associate Director for the Northwest Geriatrics Workforce Enhancement Center, which is sponsoring this lecture series along with the School of Nursing and the Deterney Center for Healthy Aging and nursing's continuing nursing education. Just a reminder to all of you out there, particularly site coordinators, to please fill out your profile forms if you have not filled one out yet for this series, and you should have evaluations and handouts for this lecture. Today I am very happy to introduce to you Hilaire Thompson. Her program of research is focused on both preventing and improving outcomes from traumatic brain injury, with a particular emphasis on older adults. She's presently conducting research to evaluate how the immune response to traumatic brain injury is influenced by age and its relationship to outcomes following TBI. Together with collaborators at the UW and elsewhere, she's also examining ways in which technology can aid in injury prevention or assist in the recovery process should a traumatic injury occur. She uses a variety of approaches in her research, including basic science, clinical epidemiology, and qualitative methods. She's actively involved in professional organizations such as the Gerontological Society of America and the National Neurotrauma Society. She will be lecturing. We'll hold questions till the end, but once you get the signal from me to get your questions ready, I will read her the questions in the chat box, and we will move from there. And welcome, Hilaire.
So thank you to the GUEP for the invitation to come and talk about what I think is a very important topic. And we are now completely locked and not moving forward. Okay. No, the slides are not.
Oh, it's locked. Okay. Apologies.
So that's okay. Okay, great.
There you go. Should be working now.
Okay. So you all should have the learning objectives, so I won't read those to you, but hopefully we'll get through. I've planned those to meet the learning objectives if there are questions. I wanted to start specifically talking about the prevalence of neurologic disease, just because I think it's underappreciated that actually neurotrauma by 2030 is going to be the leading cause of death and disability worldwide, and this is against all ages. And mostly it's actually related to a lot of motor vehicle crashes. We actually don't call them accidents in the injury field because we believe they're actually preventable, and so we don't like to use the term accident. So motor vehicle collisions, crashes, pedestrian versus auto or other sorts of things. They're also, the neurologic disorders are the primary cause of disability in older adults. So this definitely impacts quality of life, it impacts caregiving, and it results in quite a bit of disability in those older than 50 years of age, and can result in 90% of individuals, it's a little dated, having some serious dependency afterwards. So despite the fact that older adults only constitute 12 to 13% of the population in the United States, they actually represent 25% of trauma admissions. So this is not a small population of patients that we see with inpatient. They're also not a small percentage of patients that are presenting to emergency departments, nor to clinics should they feel like they didn't want to actually go into the emergency department. And we know that older adults are actually having highest injury and hospitalization rates, and this is even adjusting for knowing that we're having an increasing number of older adults just generally in the population. The rates that are adjusted for numbers of the population are still increasing. And part of that may be because of increased awareness and increased reporting, increased awareness of, certainly within newspapers, on television, a lot of emphasis on traumatic brain injury, so people are more familiar with it, so people might be presenting because they're concerned about symptoms. And then also there have been educational campaigns, particularly by the CDC, for example, on older adults and head injury, but also like the Heads Up campaign. So I think it's more on people's radar to be thinking about this, and that it's not just a bump on the head. A lot of times you used to think, oh, it's just a bump on the head, it's not a big deal, but now people realize that there are potential increased sequelae. Injury is the third leading cause of death in persons 55 to 64 and the seventh leading cause of death in those over 65. And so again, injury is a big factor. And then 25%, again, thinking of those 12 to 13% of the population, and actually they're well overrepresented in those that come in for brain injury. And more than, and this is true for not just older adults, but all populations, the vast majority of these head injuries are considered mild. And I put mild in quotation marks because a mild injury is not a mild injury. It's not something to just brush off. Mild injuries can have very long-term sequelae. They can have significant impact on the person's functioning. They can have significant impact on the patient's quality of life. And so I say mild, that's just based on the Glasgow Coma Scale rating score of how we rate mild, moderate, severe at the time of patients presenting. And it is the vast majority of people have either no alteration in their Glasgow Coma Scale or a mild 1-point alteration to be classified as mild. But again, this can have long-term symptoms, long-term outcomes. Again, similarly to injury, we have highest rates of death and hospitalization in those in older adults, particularly those 75, and then again, 26% of TBI deaths were related to those 65, even though, again, only 12% of the population. And one of the things that I think is kind of, it's concerning. When we look at the rates of hospitalization, and I used to have a slide when I first started in the field of brain injury that looked at 2003 rates to 2007 rates, and it's very similar. So the trends have just continued in that you can see what I've done is I've taken from this, I'll use the arrow pointer. We'll see if this works. So taking the arrow, so these marks, the black bars, are actually bringing over the 2006 rates, which are on the left-hand panel, over into the 2013 panel. So you see for the 0 to 4, the 5 to 14, and the 15 to 24 that there's a drop. So we have had fewer head injuries in younger aged populations in the United States. And this is a consistent trend from 2003. However, when we go over and look at the older adults, looking at those 65 and older, we have had increased prevalence of injuries, and this is a continued trend. So what are the factors for this? Could it be the increased recognition, more people potentially who are on antiplatelet, anticoagulation, who might have more severe symptoms and present? There could be a lot of factors, but there also has been a really great emphasis on helmet use, safety in playgrounds, to really emphasize the factors that would reduce the risk of brain injury in younger adults. In older adults, the primary reason why individuals end up having an injury is fall, for both the fatal and the non-fatal. And anybody who's working with older adults knows that we have some things that work in falls. We'll talk about the prevention factors later, but that we still have a great deal of work to do on fall prevention. And this is not necessarily, a lot of people will assume that the brain injuries are ground level falls in older adults. And that's absolutely not true. There's certainly a high percentage that are, but I have plenty of patients who come in, they took their, for example, antihypertensive medications and then decided to go out and go up the ladder and clean their gutters, and got syncopal and had lightheadedness and then fell off the ladder and had a head injury. So it's not necessarily a ground level fall that's resulting in the injury. A lot of people are very active, they're engaged, but there's a kind of a lot of different factors that go into this. Also looking struck by against, could be struck by a car, struck against something. Again, motor vehicle crashes, traffic accidents, and certainly looking at fatal injury, there's a high prevalence of suicide by firearm that people are, I think individuals are aware of, and so looking at prevention activities around gun safety and screening for depression and suicidality. So there are certain race and ethnicity factors that look at just who is likely to become someone who is more at risk for injury. Certainly in TBI as a whole, and also in older adult populations, Alaska Natives and Native Americans have higher prevalence based on the population. Gender, generally, this is certainly in the younger age groups, it's a disease of males. A lot related to risk factor taking, those sorts of pieces. And that still translates into older age groups, except when you get above 75 years of age, and mostly because of just the population that is still alive over 75. There are some evidence for improved survival and functional outcomes of women compared to men. That led to actually trialing looking at some hormone therapy as a potential treatment therapy in traumatic brain injury. Unfortunately, what worked in animals didn't work in the great and large human trials. But some more work has been inconclusive, so it's not really clear what the benefit of being an older female is over an older male. Certainly in younger females, there seems to be a bit of some protection related to hormonal factors. When we think in general about risk factors for injury in older adults, there's a lot of comorbid conditions that just to be thinking about as you're approaching patients, thinking about them that are going to put them at increased risk. Frailty certainly related to muscle strength, potentially deconditioning. Depression is a risk factor for general injury. Diabetes related to glucose control, and it also can be related to if someone has neuropathy. Syncopal patients who have a history of syncope. Those with orthostatic hypotension, those with actually even postprandial hypotension, that you see hypotension with eating, can be an increased risk factor in some individuals. Dementia is associated with increased risk of injury and brain injury. Cataracts, other vision problems, incontinence because of having a lot of particularly urge incontinence related to need to get to the bathroom quickly. Alcohol use, which is very actually underappreciated, underscreened for in the patient population coming in, and certainly a prior history of falls makes people more likely to have another fall, and so that's one. In looking at medications, we actually, there is information CDC, if people are not familiar with it, through part of the study toolkit, has actually a screening tool for looking at medications and risk of fall, and certainly we're in the trials that we're doing, we're using that particular toolkit as a screening factor to start a conversation with patients so that they can engage with their providers about their medication lists, looking at benzodiazepines, psychotropic medications, and certainly anticholinergic drugs. And a lot of the drugs that are on the Beers list for don't use or use with caution are showing up on ones that also increase the risk of injury. There is an increased risk with use of antidepressants. The question is the type of antidepressant. It's kind of varied across the literature, and is it related to the fact that the depression is not fully treated, fully resolved, or is it really related to the fact that they're on an antidepressant, maybe a tricyclic, that would have some impact? And then a little bit, again, diuretics, some of the antiarrhythmics and digoxin, but can't, other than the diuretics, potentially with an increased surge, not really clear on the mechanism there, but things to screen for, think about, are there alternatives in prescribing that might be something that you could think about with the patient. Outcomes, older adults are more likely to die after head injury of any severity. They're also more likely to be dependent following the injury than those with similar injuries. They will be with us longer if they're inpatient, so they're going to have a longer length of stay. And then the other thing that we've seen that's kind of unique in the literature and work that others have done, and then we've done in our group as well, is that they might have a trajectory that they're actually recovering for some period of time, and then at 3 months there actually starts to be a declination. So at a time that there's improvement, and then they have this declination 3 to 6 months in their function. And it's not really clear the mechanisms. We're looking at some of those biologically to understand why this kind of secondary decline is happening. And related to the longer length of stay, increased dependence, the cost of TBI in older adults is higher than similarly injured younger adults. Just one of the things to keep in mind that we know in the traumatic brain injury field that I think is we tend to lump it together. We say traumatic brain injury, but a traumatic brain injury is not a traumatic brain injury is not a traumatic brain injury. The brain has many parts. Those pieces of the brain actually do different things. And so really thinking about what is involved, the type of injury is quite important. So if you're thinking about patient comes in and has fallen backwards and has an occipital lobe injury, the types of issues that I would be thinking about the patient having are related to vision, versus if someone has a frontal lobe injury, which is responsible for executive function, the different types of symptoms that one is going to see based on where the injury is actually occurring will be different. And certainly things like concussion, diffuse axonal injury, in fact, impact the whole brain. And so is it a local, focal injury, or is it something that is a diffuse injury? You have to think about those in context as well. But remembering your correlative neuroanatomy of what part of the brain was injured, what is that part of the brain responsible for, what are the connections, is the patient right or left hemisphere dominant? Those sorts of things are important to keep in mind. So I want to shift gears a little bit here and just talk a little bit as background, what actually happens with normal aging and what are those implications for a brain injury in an older adult. And so with normal aging changes, we see neurochemical changes, a reduction in a variety of neurotransmitters, including serotonin, noradrenaline, maybe some reduction in dopamine, and norepinephrine. And so we have a reduction in the variety of the neurotransmitters normally with aging at baseline. Reduction in receptor density. So those neurotransmitters won't have as many receptors on various neurons. We don't have the turnover as quickly as well as the receptors. You have a receptor neurotransmitter interaction, it's not going to release and transfer over. And then also having change in regulation of those receptors. And so that can slow down processes. And so that can be relating to the neurochemical changes can relate to actually synaptic functional, what you see as like speed of processing or transmission rates. As far as anatomy, we also see changes. The panel on the right is looking at the size of the brain with age. We all have a shrinking brain with age. And mostly because of loss of volume. The cells don't have the same volume. It's not actually generally a loss of neurons. It's generally a loss of the size of the neuron. So there's a general shrinkage, and that actually changes some things. We do have some pruning and moderate loss of synapses, so the nerve-to-nerve connections. There's some pruning that happens normally just with aging processes. If we think about, you get really good at it, you're developing, having a lot of things going on, and then, I don't know, you become a college professor and you do certain things a lot of the time. I don't use some of the other parts of my brain that I might other times, so those kind of prune back, and I really work on facilitating the tracks that I'm using a lot. And so that's natural over time, but it can create, if we had an injury, sometimes you have to regrow some of those connections. The similar thing in stroke, you're having to regrow, reconnect places that are injured, but we do naturally have a modest loss of these. The dendrites lose some length, they lose some width. We also have, again, that pruning factor that happens, so we actually lose some of them. Synaptogenesis, there's a reduction in this. And then the microglial supporting structures for the brain are actually deteriorate, can actually have some priming factors that relate to the immune response as well. And so all of these factors relate to, particularly when thinking about the shrinking of volume, if you think about the head as a fixed container, we think of it as the easiest way to think about it is it's a box. And so you have a box, which is fairly rigid. It contains brain, which is about 80%, blood, which is about 10%, and cerebral spinal fluid, which is about 10%. We've now taken that 80% of that brain, and with the neuronal shrinkage over time, we now have more space. It's more potential space for things. So if I fall and hit my head, and I've now got a bruise on the brain and hematoma that's forming, there's more space for that to grow without it actually causing a shift or causing symptoms. So sometimes this can result, this shrinkage of the volume of the brain results in delayed time to seeing symptoms in older adults, which means delayed time to them presenting for care. And some
All right, we should be back online now.
Okay. So continuing with some anatomic changes, the age of onset of cerebral amyloidosis generally in the 70s, and this can result in some softening of the brain, also increased risk for intracerebral hemorrhage, so the type of injury that can happen with aging changes related to this, and this correlates to amyloid deposits in the cardiovascular system as well. The atherosclerotic changes certainly can impact blood flow, can impact some of the vessel responses. It may impact, although it really hasn't been examined really well, how the brain is actually responding after injury. And then there's issues around melanin pigment changes, and then we actually have a decrease likely related to some cell loss and with pigment cell loss. And so this is important for REM sleep. And so naturally older adults have issues or less REM sleep. And so this can be responsible for normal aging related sleeping changes, which injury can exacerbate, or certainly sleep deprivations, issues with sleep can be a risk factor for injury. So cerebral autoregulation, we know that cerebral blood flow is constant. We normally regulate it with our cerebral perfusion pressure. This is something that gets changed with trauma. So we actually have issues with our ability to autoregulate with more severe injury. But the interesting thing is that for older adults, it's in patients with hypertension. We actually have acute blood pressure reductions even when blood pressure itself is normal, and so we can think of this actually resulting, if a patient with hypertension presents with, and it's uncontrolled, and they come in and now we're making them normotensive clinically, it actually is likely underperfusing that person's brain. And we certainly know that from the stroke literature that we don't want to reduce an individual's blood pressure too low because we can actually extend the injury. And this hasn't really been well studied. It's something that we have a big interest in with the group at Harborview Injury Prevention Center of looking at what are the vascular reactivity changes with patients with hypertension, which we know the prevalence increases with aging, and are we dropping blood pressures too low? Are we keeping cerebral perfusion pressures after injury not in the correct range for that brain to get the blood, the oxygen, the nutrients it needs? And so this is a factor that we're looking at, but there's definitely changes in cerebral autoregulation with hypertension, and there might be some factors there to be looking at as well. So subdural hematoma is one of the classic types of brain injury that we see, and it's certainly one of the, with older adults coming in with more moderate to severe head injury, we certainly see it quite frequently. And the factors that this is one of the types of injuries that we see in older adults can be related to the fact that a higher proportion of older patients are on anticoagulants. And then again, that cell shrinkage that happens with aging can hide and mask some of these symptoms. So those patients may present later for care. In this case, this is quite a bit of blood this is the left picture, but it's actually the right hemisphere of the brain as you're looking at this, and there's actually a shift in midline, so this person is actually presenting with some herniation symptoms, but presented quite late. So we may not see the change in the Glasgow Coma Scale until much later. Physiologic changes that we can see are listed here. One of the things that naturally will happen with older adults, as we're doing a neurologic exam, there are some natural changes. So it's not related to injury, it's generally related to the, so not thinking that it's related to injury when it really is an aging change. But we can see pupillary changes, decreased side, delayed reactivity to light and accommodation. And this is related more to the changes in the muscle sphincter of the pupil, not really neurologic changes themselves. So when you're doing the neuro exam in the older adult, this would be a normal expected finding that you're going to see a bit of delayed pupillary reaction compared to a younger adult. Implications for other systems related to normal aging changes. We can see gait and muscle strength changes. It could be related to sarcopenia and thinking about your person with frailty. You can also have delayed neuronal impulses. So you just have to put that in context as you're approaching the neurological assessment of the older adult. With cardiovascular, we can have changes in baroreceptors, loss of heart rate and blood pressure variability. Patients may be coming in on beta blockers, which might also kind of change the dynamics of what's happening with trauma. Increasing the risk of, we can have an increased risk of syncope in these patients, and that's certainly a potential for a risk factor for injury. Respiratory, just a normal change is is the loss or diminishment of the cough reflex. And so this could be something that you're trying to elicit in an exam, or it could put the patient at increased risk of having secondary complications like microaspiration later on. GI, again, increased swallowing issues, loss or diminution of gag reflex as well. And then the sensory, hearing, and vision changes may put the patient at risk for injury in the first place, and it actually can, if we don't accommodate for those particularly within the inpatient setting, can put patients at risk for delirium, which is certainly a complication that we don't want, and it's particularly difficult to deal with in patients in the ICU with head injury, not just older adults, for the simple reason that we don't have any biomarker, we don't have any way to say, is this neurologic deterioration that we're seeing related to delirium, or is it related to head injury? And that's a very complex assessment in trying to tease it apart in that patient, and even with a really good serial exam and really following them and understanding the waxing and waning, is it the injury and worsening, or is it delirium? And trying to tease that apart can be complex. So we were looking, and we're now looking at revising this. The paper was published in JAGS almost 10, 11 years ago, looking at what the epidemiology outcomes and the future implications, and a lot of these haven't changed. So this is kind of a scoping review, and again, really looking at the fact that older age is just an independent predictor across all studies for worse outcomes of all level of brain injury. And the change point for where we see worse outcomes actually can be as low in studies as 30 years of age, that's the change point for people. So in the trauma literature, we actually consider anybody 55 and older as an older adult. And we have different triage rules for how someone is going to be triaged at 55 than they should be at 65. And just thinking about this. But the question that we started to ask in looking at the literature was, is it really age? That's what the TBI literature would say, that, oh, they're older adult, they're just not going to do as well. There were certain things, but what is it about age? How do you tease apart what is that factor? So we really started to look at what's the role of biology. And a lot of the work that I'm doing right now that I won't get into is really looking at with the immune response. We know that older adults often have chronic conditions that can cause inflammation. There's priming of microglia in the brain, and then this could create potentially a chronic inflammatory state. So if you think about a wound that won't heal. And so is this what's happening? Are there other underlying biological changes that happen with the relationship of age and injury that could be causing these differential outcomes? And so we, along with a number of groups across the country, are looking at this question. We also had the question, certainly prevalence of chronic conditions is increased with older age. So we actually looked at what's the effect of comorbidity. Is it not really the age that's the issue in outcome? Is it really the fact that someone has a chronic health condition, and that's the synergy between the two that's the difference? We first started to try and characterize what are the chronic health conditions that individuals have, and I don't think that it's going to surprise a lot of people to see hypertension at the top of the list. It's certainly most prevalent. Diabetes, cardiac arrhythmias, chronic pulmonary conditions were also seen in other studies of older adults with TBI. But in contrast to some other studies, we and now other people have replicated that alcohol abuse is actually one of the more common comorbidities. And it actually isn't still well screened for in older adults. There's a lot of assumption. I happen to work in a hospital system where I was talking to one of the ER physicians, and they're like, oh, I'm talking about, did they screen for alcohol at the time of older adults coming in for head injury with fall? And they said, well, no, they're going to fall, so therefore we're not going to test for it. So there is still this bit of a stereotype around this is a normal response to aging, even though they're kind of questionable circumstances. And so one of the things that we can do as clinicians is just have that suspicion, think about it, is it a possibility, and not just discount it because of someone's age. We also looked at a number of different factors. Clearly, some factors are going to play more into what you're going to do with the older adult or think about things. But In looking at this study, we did look at discharge function at discharge and did not find any relationship between any of the chronic conditions or groups of chronic conditions and function at discharge. So we certainly found a difference in the risk, the prevalence of the condition and risk of injury, but not that that made a difference at function at the time of discharge from the hospital. We have looked at other data sets from other groups and looked at function and looking at particularly vascular comorbidities, and we described those as patients with hypertension, patients with known cardiovascular disease, known cerebral vascular disease, and we also used vascular dementia as part of this. And so in looking at patients with low versus high vascular risk, we actually found that there was a difference, that patients who had a high vascular risk were at 3 months post-injury had lower physical functioning. There was no difference in the mental function scores, emotional health, but there were difference in physical functioning. And this has kind of led us down the pathway of looking really at the hypertension, cerebral autoregulation, vascular changes. And is that something that we need to pay more attention to? Because currently the clinical practice guidelines for at least severe traumatic brain injury have a one-size-fits-all model. You treat every patient, look for CPP within the same kind of guideline range, and should it be different with patients with hypertension than without? The stroke literature, subarachnoid hemorrhage literature certainly has those differential outcomes in their guidelines for care. And so this is something that we're particularly interested in. We've also been looking at, it was discharge outcomes. This was 3 months. We were looking at, does it increase the risk of mortality? And again, we didn't find that the presence of a comorbid health condition in older adults were responsible for any changes in mortality at the time of discharge from the hospital. But when we looked out farther at 1 year post-injury, the patients who had higher issues with chronic disease were more likely to be dead at a year than those who did not. And so there is, what we took away from this, we did a number of adjustments in looking at this, is that when in the trauma field, the most important outcome for us, the one that when trauma centers are certified, is is the person alive or dead at the time they leave. And some places will look at 30-day outcomes, but really, is that the most important thing if someone's alive, dead, or goes to a skilled nursing facility or goes home at discharge? It really is what's happening when the person gets out to the community. And because those outcomes have not really been studied and have not really been, haven't been having to track as part of trauma center credentialing, or even within the National Traumatic Database, which is done by the American College of Surgeons, that lack of emphasis on longer term outcomes provides a real opportunity for us to really think about transitions of care, handoff in care. What does this mean for the individual? Is there other opportunities for risk factors? So we're really, a lot of our group is now focused on really what is that transition period, trying to get actually better data collected in national trauma systems around at least 3-month outcomes, if not later term outcomes, so that we can really understand what is happening in that phase that could make a difference. So I think that there are opportunities for care in the handoff transition, management of those comorbid conditions in the context of having experienced a TBI. We also were really interested in looking at the role of the provider in geriatric traumatic brain injury outcomes. We know from work Linda Sheets and other groups that older trauma patients are under triage. The triage guidelines say the patient should go to a level 1 trauma center, the patient stays in the community in a level 2 or level 3. And there's certainly different reasons. It's not just the provider role. There's certainly some patient family factors related to why someone may want to stay in the community. But we also know that older adults are less likely to receive a health promotion outcomes or health promotion interventions or be offered them than younger adults. There also can, anecdotally, we just saw clinically that people would potentially treat someone with similar injuries different just based on age. There's been some opinion pieces or thought pieces in the literature talking about, do we have a perspective of therapeutic nihilism for this patient population? So it led us to really looking at bedside care issues. So we know older adults, less aggressive treatment, not necessarily getting health promotion programs. And so we were looking at is this a self-fulfilling prophecy that we just assume an older adult isn't going to do well and so we don't treat them as aggressively, and they don't. So again, work from Linda Sheets and other groups. It's difficult to actually correctly triage older trauma patients. There might be those age-related changes. We get asked a lot, is this age or is this injury? There might be some things that are really age-related that make things difficult. Medications, I mentioned beta blockers, so they, a patient who you would maybe has a blood loss, you're not expecting it, they don't have the same heart rate response that you would expect, but it's really related to the medications that they're on that are masking some of these things, comorbidity and other injury factors that might relate to it. It might be a lower impact or ground level fall, but still have similar impact. And then under triage just happens across studies, even with attention to this issue, patients don't necessarily get to the level of care that would be recommended in the guidelines. The other piece that plays into this is that we were really interested in is, okay, if comorbidities may make a difference, and if we might, and medications maybe make a difference, contextual factors may make a difference, are we getting an accurate history on our patients coming in? And to be very honest, a lot of the focus on trauma is saving the person's life, getting them, stabilized or as stable as possible, get them to the OR. So there is a focus on the advanced trauma life support criteria. But in thinking about the fact that we know that if patients are on statins, they tend to do, and you keep them on statins, they do better if you don't stop. Some of the like ARNP that they're on, if you don't stop it, they tend to do better. So there's medications that we should know about, not that we would want to start necessarily in the inpatient setting, but that would be beneficial to the patient to continue. We did a study looking at the whole entire hospital stay for older adults with head injury, and we actually found that 15% of patients, even at discharge, had no information in the medical history. So I buy from a provider perspective, I'm working on saving your life, and I don't really know this, but the fact that the average length of stay was more than 20 days in this population, that's adequate time to be able to get an adequate history. A lot of times patients won't have they can't tell you, they don't necessarily have a family member, but also letting older adults themselves know it would be important to carry a card. That would be very useful with their current medication list and chronic health conditions, name of the primary care provider, those sorts of things. When we did see the patients had a documented history, at least more than 80% had some sort of chronic condition that was going to impact our care provision. And then this can, if we don't know this, then it can complicate our diagnosis, our approach, our treatment. And so again, reinforcing to us as providers, clinicians, that we need to be asking these questions, seeking out those resources, family, other, trying to find PCPs. Care Everywhere, I think, is the best thing since sliced bread, personally, if you're an Epic user. And that's really been helpful to me personally, to be able to go into the record and find some of those information that you wouldn't necessarily have from the patient, or can the patient provide that. The other thing, in looking, and these are older data, not from our group, but looking at if someone has had a fall, and looking at what the type of treatment that would be recommended based on guidelines that they have. And we know orthostasis increases with age. It might be a contributor, but only 6% of patients after a fall had evaluation. So we're actually not doing the recommended evaluation of patients who are experiencing potential mechanisms for injury. And so there is a provider factor in that we're not necessarily doing the things that we should be doing for this group of patients. We also looked in the intensive care unit. This is data from the national study of the cost and outcomes of trauma, and looked at whether or not patients were getting the same intensity of care. What we did was use what the standard of care based on the head injury guidelines was for what patients should be receiving, and did they receive it or not, and if they didn't, did it make a difference in outcome. And so just looking at the unadjusted models, patients, again, we similarly found that patients were not, with increasing age, there was a difference in triaging to a designated trauma center when patients should have been designated. Looking at, I can get the thing to show up again. Here we go. So looking originally in the younger adult sample, looking at 25 to 54, 79%, where you see only 53% of those over 75 were actually correctly triaged to a designated trauma center. And so quite a big difference. ICP monitoring would be the standard of care for these patients in the United States. And if we look at the likelihood of having an ICP monitor placed to be able to assess what's actually happening in the head in real time, 16.8% of patients who were younger had it, and that decreases with age to less than half of those 75 and above. And then looking at critical care consultation, less likely, and but it wasn't statistically significant, but the other factors were. And we looked at, were patients perhaps do not resuscitate? Were patients perhaps, or do not intubate? Were there differences in what people's information about their healthcare plans and goals of care were? Did that make a difference? And most patients had, and similar to other studies, had them written while they were in the hospital. So the fact that this was not something that was playing a factor in the initial care and management of the patients. So really there is a less aggressive, less standard of care for what's based on the literature offered to older adults. And so certainly we argued in the paper that there might be some issues around what we do offer, and not saying that everybody should be offered everything, but that there's certainly underutilization. We also looked then, that was inpatient. We were really looking at what's happening inpatient with what we're actually delivering as far as care goes. This was then looking at once the patient was discharged from the hospital in the year post-injury, again using the same National Study of Cost and Outcomes of Trauma, so the NSCOT study. And we actually found that there were significant differences across age groups of older adults and the services that they received and offered in the outpatient period that made a difference on outcome and costs. And so with healthcare utilization, looking at differences, older adults in the oldest age group, 75 to 84, were more likely to be rehospitalized or be placed in a nursing home, which was influencing care. They were less likely to have physician visits post-discharge related to the injury. So again, that piece of that follow-up care, that transition of care was kind of missing. Interestingly, across all the groups in the year post-injury, even though there's certainly some sequelae, maybe some PTSD, anxiety or depression related to functional changes, mental health provision was not offered very often to anybody, but certainly as adults got older, the less likely, and not even on average a 1/10 of a visit to anybody. They were more likely to receive paid home health care, and were also more likely to have receipt of care from friends or family, and that's the number of hours per week that someone on average was getting. So there's a decrease in what we're offering as far as service provision. We also looked at like PT and OT, that older adults were getting offered post-discharge, and a difference in where care was being provided, and certainly more caregiving impact for individuals as well. So really looking at what we're offering to individuals. Are we providing adequate follow-up? Are we offering those sorts of pieces? The other thing just to sort of think about is the environment that we place our patients in. If they're severe brain injured patients, they might be in a critical care environment and experience, again, sensory overload, sleep disturbance. We certainly know happens in most inpatient settings. There's certainly early mobility is a factor in a lot of critical care environments. It's still not clear in traumatic brain injury patients how early is too early. And so there's some work in animal studies and some in humans. They've at least with brain injury, that if you force too much activity, it actually can be bad for the brain in the first period. And so should there be some sort of restful or reduced exertion before you start sort of mobility? And so that's something that hasn't quite been worked out. But we might also be inducing either physical or chemical restraints in these patients. They might have difficulty with communicating if they had vision or hearing changes. Are they hearing aid users, and did they get lost in the accident and not come in? And so all of those things can put patients clearly at risk for delirium. And again, that sort of conundrum of being in that environment, the risk factors, and thinking about that, and just doing really good delirium prevention is really critical. So what approach should we take for patients who are presenting with head injury? The initial assessment, we want to actually get history factors, what happened, how were they injured, did they have any change in their level of consciousness, was it altered, did they lose consciousness, how long, and what was that severity? Are they having symptoms? Did they have a head injury before? Are there any other conditions that could be important? things that we think about that are particularly like kind of top of the list, obviously loss of consciousness. Patients might be amnestic, so they're not remembering the events, they're not remembering events going forward. Are they having headache? Are they having dizziness, nausea, vomiting? People will say like their bell's rung, they kind of hear like the ringing. So what are those kinds of symptoms that people are experiencing, and can they express them? Neurologic examination is cornerstone of care still. In the serial neurologic examination, we want to see what's baseline. Are they getting worse? Are they getting better? And so the mental status testing, looking at memory, if you're able to elicit that from the individual. And then for patients with mild, we want to know not only what symptoms they're having, but if they start to walk, do the symptoms get worse? Because exacerbation of symptoms with activity for those 80% of patients who are coming in with mild is an indicator that their concussion, their mild head injury has not fully cleared. And so that's an indicator for how we're going to approach treatment. Checking pupils, coordination, we want to check is sensation intact. And then generally the rule of thumb is in patients you'll do an initial exam. It might be a little more frequent in the first hour, but then generally hourly until they return to baseline. And any decrease in neurologic status, if nurses are assessing it, should be reported to the provider. If the provider sees it, then doing those pieces. So there are CT criteria. One of the questions coming in is which patients with mild traumatic brain injury should get a CT. Obviously, if someone's coming in with decreased level of consciousness, they will get a head CT. But who of those mild group of patients should be getting a CT? And the two criteria that are both within the literature, they're validated, are the New Orleans criteria and then the Canadian criteria. And different settings may use different ones, different providers may use different ones. The New Orleans criteria, this is a person who presents at the time of the ER or to the maybe provider's office, and they're neurologically intact. So their Glasgow Coma Scale is 15, so they've got normal pupillary responses, normal motor strength, and normal verbalization. They have specific criteria, and notice that age is a criteria. So anybody over 60, because of the changes, should get a CT to make sure that there's no intracranial injury that needs to be monitored. And so age alone is a criteria within the New Orleans criteria. And they both have good sensitivity. The Canadian is a bit more specific. This is looking at Canadian criteria in contrast. It's not looking at 15s. It's looking at someone who has a less than 15 GCS at 2 hours post-injury. And again, age is a criteria. So anybody over 65 who has a GCS less than 15 at 2 hours, they're recommending getting a CT. And certainly, we recommend, just because of bleeding issues, that anybody who is on anticoagulations get them, because they were actually excluded from most of these studies to develop those. It's just important. People should be alert for the red flags listing here. And if patients are being sent home, their family members should be alert for the red flags of when someone should come in. And the general rule of thumb in the emergency department is we are not going to discharge somebody until the symptoms, they're back to baseline. There may be some heightened that we're not quite sure what the baseline was, and do we want to monitor them. But for most individuals, it's still going to be intact, full motor strength, alert, oriented, and having no deficits. But again, be alert for the red flags, have the family, whoever, or provider also aware. From a mild traumatic brain injury management standpoint, the other thing that's really important is setting expectations with patients and families. A lot of people will, one, I would say, that it doesn't always happen is we don't always tell patients at discharge from the emergency department that they've had a head injury. Maybe they fractured their wrist and the head injury was kind of a secondary factor. Well, then they go home and they start in a couple of weeks having headaches. They're having, more dizziness, and they didn't even know that they had a head injury. There's that, I will say that the diagnosis, even though it's probably pretty present, doesn't necessarily always show up on the discharge sheet. And so just having a recognition that we really need to set that expectation, let people know and be aware is really important. Mild traumatic brain injury patients, again, setting expectation. We want gradual symptom resolution. So I might still have, I might be back to normal strength, but I might have some headache, or I might have some dizziness. that this is not going to go away tomorrow. It's going to be gradual resolution of symptoms over days to weeks. And that expectation that most people recover, do very well, but it's going to take a period of time, can reduce a lot of the anxiety and feelings, and actually studies have shown that setting that expectation can improve recovery. There are no specific FDA-approved drugs that treat TBI of any severity. All the clinical drug trials have failed. So there's certainly more in the pipeline. People are continuing to be interested in this, but there's nothing that someone will prescribe to say this is what you would take to reduce the severity of the injury. Patients should not be placed on opioids for a lot of reasons, or sedating medications. And then because of the fact that they can exacerbate symptoms, avoid aspirin, avoid anticoagulants, and warn people to not drink because it can exacerbate the symptoms or create prolonged recovery time. We also generally recommend that we write instructions. A lot of older adults might still be working, so when can they return to work or volunteer activities, so they have a written prescription that they can take and know what to follow. And again, just because there might be memory deficits, there might be some issues, it's always important to not only make sure that you're using teach back either with the patient or family member, depending on who you're able to do the teaching with, but also providing the instructions either in some written form or some other form that is available to the patient. We look a lot at symptom triggers. We manage symptoms in this period. In contrast to the severe TBI guidelines, with mild TBI, seizures do not occur very frequently. It's less than 5% of the population. And so these are not patients that we're automatically going to put on antiepileptics for prophylaxis like we would are recommended for severe TBI patients. When to admit patients? Anytime the patient has a loss of consciousness more than 2 minutes, they should be admitted for OBS at least. And they're not back to baseline mental status, so usually observation for 24 hours just because of the potential for intracranial complications. And then hospital admission, if someone's GCS is less than 15, if we've done that, had CT scan, we saw something internal, those patients should be admitted and watched. Anybody who has seizures and anybody whose underlying bleeding parameters or on oral anticoagulation, because that's a person you're going to want to watch very carefully. So there is a decision on what's the right place to disposition the person home. You can also consider if there's no one either at home or in the setting who can monitor the individual, that might also be a person that you would want to admit. One of the questions that we get very frequently for patients, and this has also been shown in the literature, we've done interviews with patients as they're recovering, and really they have a difficult time saying, is it the fact that I had a brain injury, or is this the fact that I'm just older that I'm experiencing this? And so there's a difficult teasing out what people are experiencing. And in a way, it doesn't really matter. We should be treating things as they're experiencing the symptoms. One of the interesting things we've been looking in a natural history study that we did, looking at older and younger mild TBI patients and looking at what symptoms they experienced at a week post-injury, what an older adult experiences versus what a younger adult is experiencing looks very different. So younger adults endorse with number one symptom headache. It doesn't even show on the top 10 list of what older adults are experiencing or endorsing as a symptom. So is it because the pain experience of older adults, they might have arthritic pain, or they're just used to kind of normalizing it? We haven't explored that, but I think it's really important. We should still try and elicit, are people experiencing pain? Maybe they're classifying it something different. We also see anxiety in the younger patients, and this is a cut point of 55, so younger being 55 and below and older being 55 and above. They complain of memory difficulties and being bothered by life, but the memory difficulties, a lot of times, that's one that they are like, I'm not sure if it's really aging or if it's really injury or a combination of both. Fatigue is also really common in both groups. It's certainly more prevalent in older adults that we see, and again, that's one that people really have a difficult time teasing apart. Where's the etiology? Where is it coming from? But at least a third of TBI patients and 2/3 of older adult with TBI have severe fatigue at 6 months post-injury, and it can be very severe, can be disabling. we want to make sure that we're looking at, is it just not from the injury, or are there other comorbid conditions that could be causing this? Is this a sleep disturbance that might be relating to daytime fatigue or sleepiness? Is there underlying depression that we haven't assessed or managed very well? Are there other conditions like anemia that might be contributing to the fatigue? So making sure that we've looked at those potentially contributing conditions for those secondary causes. And then we could also look for things that we'll do, recommend periods of rest, not necessarily napping during the daytime, because that can, especially if sleep has a component, but periods of rest. Might order a neurostimulant if it really persists. This would be something that would be done generally by physiatry or a consultation with a neurologist. Referral for physical therapy, for cognitive behavioral therapy, which also has been shown to kind of help with this. And then we can do graded aerobic exercise as well. And with balance training or conditioning. Another common problem is sleep. Again, older adults have a higher prevalence of a lot of sleep disorders, can be comorbid, can exacerbate, and certainly the lack of sleep exacerbates a lot of symptoms. And so non-pharmacologic management that's been shown to be effective in doing CBTI with this population works quite well, which would include some sleep hygiene activities. There's been some interesting research on hyperbaric oxygen improving sleep, but it's not widely available and it's very expensive and most insurance companies won't cover it, so likely probably not going to see it too much. Pharmacologic management, avoid benzos just because it's not good for older adults and it's also going to potentially exacerbate other problems. Melatonin is something that can be used and might be successful if we also think about thinking back to the aging-related responses of the loss of the melanin pigment. This might be something that could be beneficial and has a fairly low risk threshold. Trazodone and tricyclics have been used as well and shown to be effective in younger adults, but you really need to balance the risk-benefit of their use in older adults and really think about that pretty hard. Because they do have some things that are not optimal. Again, memory commonly reported, but it could be really that processing speed, particularly with aging. We know that processing speed just naturally changes with aging. So giving people time to answer, giving people time to process the information that you're giving them and just allowing that extra time. So it might not be, bottom line, it might not really be memory, it might be processing speed, and there are tests to help you determine that. Again, that might be done with a physiatrist or neurologist's office. Screening for risk factors of ongoing memory problems, the list is there. And then there are a couple of memory interventions as part of an IOM panel that looked at different types of memory interventions around cognitive therapy, and the evidence is poor, is what I'll say is the bottom line of our report, and we couldn't really recommend anything, but most of them won't hurt. Restorative don't tend to work as well as compensatory. Restorative is, doing kind of cognitive challenges. You have a list of words and you try and remember them, listen to paragraph, and then say back what the paragraph meant. It's if the connections aren't there, it might help you over time to build them, but it's not necessarily going to be like a first-line strategy to help people, and it actually can create, just from personal experience, a lot of frustration in the individual, and so being aware of that. Compensatory strategies, memory books, people using calendars, lists, items on their cell phone, things like that. Pager systems have been used as well so that people are getting reminders of what to do. So more kind of compensatory for the issues with memory. We see a lot of issues with posture, balance, and vestibular issues. So really want to look at, how's their vision? Do they have any hearing loss that might indicate that they have cranial nerve 8 damage? Are they on medications and do they have side effects? Could those be contributing as well? For these things, looking at vestibular balance therapy and can include short-term pharmacotherapy, but again, the use of like scopolamine, very drying, anticholinergic, not a great drug choice in older adults. Again, you have to think about the risk-benefit. Vision disturbance, we see diplopia, blurry vision. We might be patching various eyes to kind of improve this management of environmental light, which might also have impact on people's experience of headache. as well, understanding what the underlying vision changes. Did they have cataracts before that were untreated? Are there things that we need to do around that as well? And then one of the other pieces that I think is kind of underappreciated is with patients with particularly moderate to severe head injury having developing anosmia, so they lose their sense of smell. One of the places that has the biggest turnover of neurons in neurogenesis is actually in the olfactory bulb, and so this is a rapid place that has neurogenesis, but when we age, that doesn't happen as frequently, and a lot of older adults will have decreased sense of smell, which impacts taste. So one of the big things that we see is there's safety issues with this, like not able to detect that there might be smoke or other sorts of the food is bad in the refrigerator. But it also, just the lack of smell can decrease the pleasure of eating, and so people eat less, and we can see weight loss changes, but it's not really related to appetite, it's related to loss of smell. And so just being aware of that dietary referral for those patients can be helpful in management. And there are a number of tests that, actually it's one of the screening tests to look at different smells, and developed at the University of Pennsylvania where I was trained, so no, good test. Common products, again, not so much in older adults, but you can see headache, prevalent in younger adults post-injury. Mechanism of injury, patients who have a blunt head injury, so I hit my head into the front of the windshield, so that's a blunt injury versus like a penetrating or a blast injury. Really more tension type headaches, so the things that you're going to do for tension type headaches in this population would be what the approach that you would take. Again, avoid opiates, avoid benzodiazepines, it will just make the symptoms worse. Try rest, see if heat or ice might work, individual therapeutics to try and do this. And there's no really universal post-traumatic headache treatment protocol to date. So a lot of this is individual interventions about what works for the patient, what might help in that individual. And I either start my talk or I end my talk with management starts with prevention. As I mentioned before, there is no drug treatment for head injury. There's nothing that we can do like in stroke to give someone TPA that will minimize the damage. The damage is the damage. We're really focused on trying to minimize the secondary damage. So really the management of TBI starts with prevention. And so talking with older adults about driving safety, are they seat belted? There can be differences in the, are the mirrors appropriately adjusted based on age? There are things that they can do for accommodation in their car to improve their driving safety. Where are they living and the timing of the lights? There have been some, for example, in areas where there might be a high population of older adults, changing and allowing longer times in the pedestrian crosswalk that can happen. It's made a huge difference on patient safety at various intersections where there is high risk of injury related to basically fast lights. Still, older adults biking, there was a recent publication and talking about like bicycling and getting out there, and they showed the older adults without helmets on, which just drove us crazy. So really reinforcing the helmet use, it's actually the law in King County, which I don't think people necessarily appreciate very much. Also other personal protective equipment if people are out and about, maybe skiing or whatever, using appropriate helmet use. Fall prevention, clearly number one mechanism of injury for both fatal and non-fatal, so really looking at fall prevention. Things that we can be recommending to patients, are they getting regular exercise, balance training? Certainly Tai Chi has a lot of evidence behind it. Looking at home safety checklists, again, the CDC STEADY checklist has a really great home safety checklist that you can give to your patients. There are programs that are throughout the United States that some places have, we don't particularly have here in Seattle area, but other places have, that bring a nurse and an occupational therapist and a handyman out to the home that's covered by Medicare, and actually does those changes to make the home a much more safer environment and can reduce the risk of home injury. Appropriate shoes, there's been work looking at this in relation to fall. A lot of older adults think that slippers or bare feet are actually good choices of footwear. They're not. They increase the risk of fall. So making sure they have good tread even when they're inside the home, that the slippers have good tread, talking with them about those and putting those pieces. Medication review, doing those reconciliation, seeing how patients are taking their meds, or they're taking things that we're not aware of. having vision checked regularly, and if patients do get, there's U.S. Preventive Services Task Force that's having the first cataract done reduces your risk of injury, but having that second one at least doesn't make a difference in falls. But I think I'd rather have 2 than 1, but at any rate. So that can make a difference, but also knowing when patients have glasses changes, particularly maybe take, or if they're using glasses but going down the stairs and they're progressives, then making sure where are they looking and those sorts of pieces, just for remind people around this prevention activity. The CDC actually has an education campaign. They have flyers. You can get them. You can download them. And these are really targeted, not so much as providers, but they're targeted at the adult children of older adults and the older adults themselves, called Help Seniors Live Better Longer, Prevent Brain Injury. And again, they're looking really at the children as a target audience. How would I recognize this? What could I do to make my parents safer? And also, what can they do to kind of help with other pieces? There are other references that are targeted to providers more along like the study toolkit, but these are certainly available free of charge, and you can download them and use them. And so again, mitigating the risk of falls, the #1 cause. So refer to people evidence-based CDC study toolkit. There's been a lot of work to try and increase the reach and the utilization of the study toolkit in the community. It has information on exercise programs, how people can find them, vision check, the shoes, the home safety. And then the Preventive Services Task Force guidelines as well recommend vitamin D. So, which doesn't just have impact on bone health, it also has like vestibular balance improvement. And so thinking about vitamin D supplementation in your patients, if that's appropriate, would be something to consider. Particularly, there was a more recent study looking at, does it make a difference in nursing home populations, because there's an assumption that everybody in nursing home populations wasn't getting enough vitamin D because of the sunlight exposure. And then the recent trial, I think it was in JAGS maybe a month ago, looked at it and it didn't look like the outcomes were that much better, at least on the levels, but they didn't do functional testing. So I think there's more to be said there, but currently it is in the guidelines for the vitamin D, but I would stay tuned on, does everybody really need supplement or not? And that's all I have, I think, and so questions.
So we actually have a question that's already come in, and that is, did you say that Medicare will cover a handyman to put up durable medical equipment in the home? And if so, do you know how that is arranged normally?
So not necessarily, certain states have programs to do this. We are not one of them. I know that Maryland, Michigan, there might be a couple of others. This is Sarah Stanton's work in the Capable Project. And so I think if you Google it, you can find which states this is in, which states are providing that service. So not yet in at least Washington State, nor any of our surrounding states that I'm aware of. But it's been shown to be highly effective. She's a new Academy Edge runner, and so I would hope to see this, because it makes a lot of logical sense and it's a low-cost intervention, would be something that could be expanded to other states.
So Alzheimer's Resource in Anchorage is saying, would a TBI be something that a primary care provider in an outpatient setting would screen for, or would they refer to neuro if a TBI is suspected?
It depends on I would say it depends on a lot of factors. It depends on what resources are available, the time length since it happened, and the severity of the symptoms that someone's experiencing. So I can't give a definitive answer, whether or not someone should be triaged. If they're, had a head injury, they're on anticoagulants and it's lower, they should be referred out, but a mild that is not being managed symptom-wise, it also depends on the comfort of the primary care provider. So I'm sorry, I can't really provide a definitive answer on the right time to who should refer, and a lot of it has to do with your own personal comfort level and training and resources available to you as well.
So here's an interesting one. Speaking from 47 plus years of experience as a severe massive open head TBI survivor who had a GCS of 1, one thing those of us on the long-term care side of things need to understand is that the person who survives a TBI is not going to be the same person they were before the injury. To look at it from a cultural anthropology perspective, there are 5 stages in enculturation. The last is referred to as a reverse enculturation, in which the person returns to their home culture. For TBI survivors, there is adaptation, adapting to the expectation of their home culture, but there is no reverse enculturation. Thoughts on that?
I think, I mean, probably true for moderate and severe. I think mild, there may be, but there certainly needs to be incorporation of the experience. And there's a lot of factors that go into this, particularly in thinking about, referring back to the correlative neuroanatomy, what area of the brain are injured. One of the issues, and the field is moving forward on this, is a TBI is a TBI is a TBI. Everybody, I have different neuronal connections based on mine versus someone else. And so you can have two people with exact same area of the brain, exact severity, and have completely different experiences. So I would just say every time you encounter a patient, work with a patient, it's an N of 1, and they're not going to be like anybody else, and how we have to support them needs to be individualized and supportive.
So is a TBI diagnosed, I would say, typically via symptoms or an MRI?
It's typically symptoms if it's mild, and the history of the event. MRI is not something that is typically used for diagnosis of traumatic brain injury. It's usually a head CT, usually without contrast, but that's for the more severe. But you might have someone who I will say there's not agreement on the diagnostic criteria across the world, but institutions will use certain criteria. The CDC has certain criteria for diagnosing, and it has to be certain, like change and alteration of level of consciousness, type of amnesia, experience, other symptoms. And so there are different diagnostic criteria. So it can be done just based on history and physical exam, and does not require, in all cases, a CT for full diagnosis. But again, looking at the criteria on who should get a head CT, most older adults should get a head CT. So that would be something that you would be able to say they might still have a head injury, but they might not have intracranial injury. And so those are two different populations. We call someone who has a mild TBI with like maybe a little small intercerebral hemorrhage a complex mild. So there's like some gradations even within the mild categorization, and that has impact on outcome.
Okay. Any recommendations for supporting a client who is aging in place, had past brain injury, and now needs more behavioral health support for being successful with accepting care in the home? So it sounds like some long-term sequelae from...
I think case management can be something that can be supportive. Are there other services that the person can be connected to? Are there other people that they can put in there that might be able to check on them on a regular basis? That might be more acceptable to the individual who wants to age in place. I think that is, again, that N of 1 and contextualization and thinking about your client as an individual and what might be best for that symptom. There are brain injury associations within each of the 50 states. I'm most familiar with the Brain Injury Association of Washington. They have some great resources, some great referrals, some peer support. So I would refer people to the Brain Injury Association in their state for additional resources. And they also would know the community really well and what resources would be available to individuals.
And from Laramie, Wyoming, what are concerns regarding trazodone in elderly populations for sleep?
So not so much the trazodone, it was more like thinking about the tricyclics, but I do think just the sedating nature is just, it's sedating nature, so.
Do we have questions in the room here?
I have two separate ones from the material. When you were talking about the unadjusted distribution of the care for age, and you were correlating with the decrease in resources that are placed towards an increasing age, do you think that there are some causes because of the risk of some of the procedures? Did that come into play when you looked at it? So like putting in an ICP monitor, if you're 85 versus 45, I don't know if that was looked at in terms of that was one of the reasons maybe that the decrease in offering us
a therapeutic. So the question is about, in looking at the intensity of care to patients in the intensive care unit and what people were offered or not, did we look at the underlying reasons why people weren't offered? That wasn't available in the data set. This was it offered, was it not? We did have information on whether or not they had advanced directives or if they had a DNR and DNI order, which we used as a proxy in the data set, but that was the best. So you'd have to go back to the providers to really say what was going through your mind in the decision making that you chose, in this case where it would have been recommended not to use. And we did adjust for comorbidity, but that won't handle everything in the adjustment. So I would say there likely is an association, but we can't say it's just not thinking of the individual and the decision was not inappropriate. I'm not saying that. It's just in general they were offered less.
My other question just was in terms of the common problems on the memory slide. When you talk about the screening for risk factors for the ongoing memory problems, the last category you said it was lower SES. Is that
Socioeconomic status.
What is the correlation of that with the ongoing memory problem continuing?
So it's more around, tends to have patients or individuals who have lower cognitive reserve in general. They might have not the protective effects of education, they might not. And so it's not really the fact of the SES alone, it's the fact of the opportunities that the SES provided that may be cognitively protective in a longer term situation.
I was just wondering if any of the research had looked at. I think that it's complicated when that you are dealing with an aging population, the delirium component, because there's research that shows the cognitive impacts of delirium in the hospital are significant. So how does that get teased out, like head injury, or is it possible?
So good question. So the question is how, with increasing age, increased likelihood of delirium, which certainly has impact on long-term cognitive function and recovery, and the TBI and teasing that apart. The group at Vanderbilt, so Wes Ely's group, is probably the one that is the most on top of this and looking at it. And they've been trying, and also Cindy Monroe has a new grant, and there's a group at Pittsburgh that's also looking at, can we find a biomarker? So there's been some, because you can't tease that apart really easily and it's really difficult to know, and you don't want to keep sending someone down for a head CT, and sometimes the head CT is no different, but the patient's worse, but it's not really clear that, they don't have the waxing and waning, and they can't respond, so you're not able to do your CAM ICU or even your, really well, or your CAM. So the assessment tools that we have in place are not really specific to be able to say, yes, this is delirium versus this is TBI. So there's some work to being, is there some objective marker, a urine biomarker, some sort of serum biomarker that we could look at to say this is really delirium that's happening in the context of the brain injury. As far as I know, usually the newest abstracts come out at Society for Critical Care Medicine, which happens to be, I think, this week or next. I haven't had a chance to really look at the abstract book to see what the latest and greatest is, but I will. But as far as I know, there's nothing that's been identified out of the work, but there are a lot of groups that are looking at this because of the difficulty. And the same thing with stroke patients, like anybody who's having a neurological insult that's going to impact their ability to kind of respond, or they would potentially have that waxing and waning. So there's definitely a desire to have a sort of more objective measure than what we currently have.